Happy New Year, everybody. I want to welcome you back for 2023. We're okay? All right. Well, I want to welcome you back here for 2023. It is with great privilege that I introduce Bernie Black. I am the Buehler Center Director, the inaugural director, and I know Bernie was the very first member of the Buehler Center for Health Policy and Economics. And also when I came into the office, Bernie was also the very first meeting that I had at Northwestern University. So it's with great pleasure that I have to introduce him today. First of all, we need to keep some housekeeping. There's a Q&A function in the Zoom call. If you're joining us remotely, you have to use the Q&A because we will not be checking the chat for questions. And then also I wanted to let you know that we present an IFAM public health seminar series every Thursday at 12 o'clock or noon. Bernie Black is Nicholas D. Chabraja professor at Northwestern University with faculty positions in the Pritzker School of Law and also the Kellogg School of Management, Department of Finance. In his healthcare research, he studies how health and insurance and medical malpractice affects the quality and cost of medical care with a focus on diabetic patients and the effects of hospital-physician integration on care quality and outcomes. He seeks to assess the causal impacts of legal changes and other shocks, for example, the impact of health insurance or medical malpractice reform on healthcare outcomes of infection reporting on hospital-acquired infections and of firm-level governance on firm outcomes. And with that, I will let Bernie speak here.
Yes, I do. So I have to turn this. Hey, can you hear me?
Thank you, Bernie.
All right, so thank you for the opportunity to present what I hope will be some interesting research on different aspects of the COVID-19 pandemic, where we're getting reaching different conclusions than the ones that you've heard about before. So I will present those. I'm going to look at least 3, maybe 4 topics. One is, what can we say about the effectiveness of the principal US vaccines, the mRNA vaccines from Pfizer and from Moderna, in 2022, after we allow for waning? How important is a booster dose after all? A second is, are there meaningful differences between Pfizer and Moderna in effectiveness? And our answer is going to be yes, which is not the answer that's out there in the literature. A third is, if we look at the aggregate life expectancy loss from COVID to date, how much is it? And my answer is going to be 2 weeks, not 2 years, where 2 years is what you hear out there in the literature. And then finally, if I have time, I'll talk a little bit about the racial ethnic disparities in COVID mortality, which vary greatly by age, by gender, and by time period during the pandemic. Okay, so with, let's see, with apology, I got to go forward. It's not going forward. Why is it not going forward? What's that? No, that's not working either. No, nothing's working. Okay. So I apologize, but I want to start with this. My son, Daniel, died a little over a year ago, and so I find myself unable to show up and pretend everything is well in the world. And so this is a picture of him from happier times. Okay. So for background, I'll circulate the slides. This is some of my COVID research. I'll focus mostly on the first 2 projects. I know this is too small to read, and I don't expect you to now. So I want to view vaccine effectiveness, VE, as a hard, complicated causal inference problem. We're interested in the causal effect of vaccination against some outcome, right? And so we can measure the outcome if you're unvaccinated versus the outcome if you're vaccinated. And VE is going to be a ratio. What's the extra benefit of being vaccinated relative to the unvax outcome? We can also measure remaining risk or relative risk, which is an odds ratio. It's just going to be 1 minus VE. And that's going to be the outcome for the vaccinated or the unvaccinated. You can do the same thing for 2 doses versus 1 dose, 3 doses versus 2 doses, 4 doses versus 3 doses, Pfizer versus Moderna, right? We can compute relative risk for all of those. And there are just a whole bunch of outcomes that we're interested in. We're interested in infection. We're interested in symptomatic infection. We're interested in antibody levels and which type, and also B and T cells. We're interested in severe outcomes, hospitalization, severe or critical disease, ICU admission, mortality. I'm going to focus on mortality because that's where we've been able to get the data. Post-COVID mortality from other causes that seem to be affected, a heart attack and stroke. Side effects, which ones for which vaccines. Long COVID, which has no precise definition. So lots of outcomes. And for all of these, and here I'm going to, if we have a comparative advantage, it's going to be thinking carefully about how we can approach a causal estimate. For all of these, we have to estimate the missing potential outcome. So I apologize, I won't have too much algebra, but I do have a little bit on this slide and the next one. So Y is some outcome, right? And W is, are you treated? Are you vaccinated? And I is a subscript to index individuals. And we're going to observe Y for treated persons, conditioned on their being treated. And we're going to observe an outcome for control persons, continued on conditioned on them being control. And what we want to measure is the difference between these two outcomes. The treatment effect for individual I is the difference between the outcome if treated and the outcome if control, and we can never measure this. The problem is that for any individual, they're either treated or they're control. You never get to measure both outcomes at once. So I put the unmeasured outcome for the treated in red, right? We observe one potential outcome or the other, which has been called the fundamental problem of causal inference. So what do we do about this? Well, a randomized control trial is going to ensure that treated and control are similar on average, crucially on both what we observe about you and what we don't observe about you. So if I let E of bracket be an expectation, an average over some sample, then on average, the expectation, if you're treated, your control outcome, if you're treated, which we don't observe, is the same as your control outcome if you're control, which we do observe. So then we can substitute and we can measure the average treatment effect for the treated as, let's see, I didn't want to do that. I want to go in here, right? So this is what we, let me do it here. I can't, sorry, it's just floating around. We want to measure the thing on the left, right? The first thing on the right after the equal sign, but part of it's unobserved. But we replace the unobserved control outcome for the treated with the observed control outcome for the controls. On average, we get an average treatment effect, right? What do we do, though, if we don't have an RCT? And here we don't. The initial vaccine trials were small relative to what they would need to be to study severe disease. They studied only infection. They studied only near-term outcomes before waning. They only studied the original variant, and the samples were too small to get at more severe outcomes anyway. So we have instead what we call observational studies, where the core challenge is to estimate the missing potential outcome. Some people call it a counterfactual. What would the outcome have been for the vaccinated if they had been unvaccinated, for which the only possible source of data is the controls, but they're different people. Whether you got vaccinated or not is not random. And I want to come back to that, because that's the core selection issue that we're going to want to try to address. We also have a very complex set of outcomes and treatments, right? We not only have vaccinated versus unvaccinated, we have 2 doses versus none or 1, 3 versus none, 1 or 2, 4 versus none, 1, 2 or 3, with or without prior infection, which would then lead to hybrid immunity, but we can't measure prior infection very well because we don't have the data. We can worry about the effect of different treatments, and then we really have to worry about vaccine effectiveness waning over time. So the outcome is not really dependent on just were you vaccinated, but how many doses and how long ago. And the treatment is really an additional dose some number of months after the last dose, and maybe also some number of months after prior infection. And then to make things more complicated, the dominant vaccine variant is changing on us at the same time. So all of this is a hard problem. And on top of that, we have what the causal inference literature calls heterogeneous treatment effects. Both treatment effects and side effects can vary with age, with gender, with prior health status, with comorbidities and which ones, with the number of doses, and with the type of vaccine. I'll focus here on Pfizer and Moderna, but in other countries, you have to worry about AstraZeneca, and we potentially would worry about mixing and matching of vaccines, or about Johnson & Johnson. Maybe there are heterogeneous effects with other factors, socioeconomic status, education, race, ethnicity. Don't see any evidence of that in the data so far, but that doesn't mean they can't exist. So what are we going to do about selection effects? The vaccinated and unvaccinated are different. We did not have mandatory vaccination. The 2-dose recipients are different than 1 dose, 3 doses different than 2, 4 doses different than 3. The people who rushed out to get vaccinated early are different than the ones who took their time. The usual imperfect response is to control for covariates that you can measure about somebody. And then you hope that the treated and control are similar on what you can't measure about them. And you can use regression analysis, you can use matching or balancing or both. But in many studies, what we know about you is limited, often only age and gender. For infection, we see test negative designs all the time. You tested positive versus tested negative. Okay, that controls for your propensity to get tested, but the people who get tested are different than the people who didn't get tested or got tested later. Combine that with there's been intense pressure to produce results fast. We want to know, do boosters work? And we want to know it now. And so there's this worldwide race to publish, which leads to a focus on short-term results, sometimes too much so, I think. That means you work with the data you have despite its limitations. For example, little data on comorbidities. You work with the sample you have. So we get many studies of limited populations, of hospitalized patients, of healthcare workers, of US veterans. There are wonderful studies of US veterans. Do they generalize beyond US veterans? I don't know, right? Great studies coming out of Qatar, but it's a very young population. The problem is curating a richer data set takes time, IRB approvals, and so on. But if you work with limited data and narrow samples, you end up with selection bias. So given all that, what do we do that's new? So limitation, we're going to study only mortality. Advantage, it's an important outcome. It's surely correlated with other outcomes like hospitalization. And we have population level data. We can get death records for all decedents in a given geographic area. And we can study a substantial time period at the state level, at least by getting the mortality data from individual states. The disadvantage is we have limited individual characteristics. We only know what's in the death records. So what are we going to do? This is the core move in much of our research. The conventional measure of COVID mortality is the population fatality rate. We just take the number of deaths and we divide by population for some sample. Sometimes instead, people will study all-cause excess mortality, which is deaths minus expected deaths projected into the COVID period from the pre-COVID period divided by population. We're going to look at a different outcome that I'm going to call CEMP, C-E-M-P, the COVID excess mortality percentage. And what we're going to do is count COVID deaths for a group defined by age and gender and race, ethnicity, and maybe SES, divided by non-COVID deaths from natural causes, from other natural causes. And the idea here is natural causes, everything except murder, accident, suicide. The people who are more likely to die of COVID are more likely to die of everything else too, right? COVID hits the elderly, so do other causes of natural death. COVID is more severe for men than for women, so are other causes of natural death. And so the idea is that if we can control for your risk, and you have to do this at a group level because individuals either die of one thing or the other, but not both, of dying of other things, we have done a decent job, and I want to suggest I will show you a good job of controlling for selection effects in who got vaccinated and which vaccine they got. So that's the core idea for studying CEMP instead of PFR. We control for an observed group difference, your likelihood of dying from other natural causes. I'm going to show you that that strongly predicts your likelihood of dying of COVID in the pre-vaccine period when everybody's pulled together. And I'm going to show you that using non-COVID natural mortality, the vaccinated are healthier. It might have been that the sicker people ran out to get vaccinated, but it turns out the healthier people ran out to get vaccinated. They have lower COVID mortality, even if not vaccinated. We do a good job of predicting COVID mortality pre-vaccine. And so we hope that we're predicting reasonably well the missing potential outcome, the mortality risk of the vaccinated if they weren't vaccinated once vaccines are available. And studies that don't control for a selection, if the vaccinated are healthier, are going to overestimate the effectiveness of the standard original 2 doses of vaccine. That means they're going to underestimate the extra protection from the booster. Because if the 2 doses aren't as good, there's more room for the booster to help, and I'll show you both of those. So, core slide, non-COVID natural mortality rate on the x-axis, predicting COVID deaths in the pre-vaccine period on the y-axis for groups defined by age group, by gender, by race, ethnicity, and by quintiles of a measure of socioeconomic status. This is pretty remarkable. This is a correlation of 0.97. This is data from Indiana. Non-COVID natural mortality does a very good job of predicting COVID mortality in a period where there are no vaccines. And so what we're going to do in the period where there are vaccines is we're going to use non-COVID mortality to adjust for the different health of vaccinated versus unvaccinated groups. Okay, data sources, we're going to use mortality records from Indiana and Wisconsin. We're going to read the death certificates. We're going to use text analysis to count COVID deaths. We're not going to rely on the ICD-10 codes from the National Center for Health Statistics. They undercount COVID deaths. We don't, because we just do a better job of counting, and I'll show you that for Wisconsin. Our data right now comes from Milwaukee County, Wisconsin. I'm going to get more data from Indiana. It's about 700,000 adults, racially, ethnically, economically diverse through June of 2022. We're going to link the mortality records to vaccination records for adults. We can link them to infection records, but we have not done that yet. And I'm going to say, but not show you, that we get consistent results for a population of about 2 million adults in Indiana from preliminary work. Okay, so COVID PFR, population fatality rate, by age, gender, and race ethnicity. Age 20 to 64 on the top, a different scale for age 65 plus on the bottom. What are you going to see? You're going to see an exponential increase in the population fatality rate with age, and you're going to see that it's higher for men than it is for women, and you're also going to see that it's higher for Hispanics and Blacks, and in our data, roughly similar for whites and Asians, okay, at a big picture. CEMP, very different picture. It doesn't rise exponentially with age. The pre-vaccine period, 2020, is in the dashed lines. It kind of rises gently with age, right? Blue is for men and orange is for women. In the vaccine period, 2021 and first half of 2022, it flips. CEMP can be understood as your extra risk of dying of COVID relative to your risk of dying of other natural things. That turns out to be highest in middle ages. The absolute risk is higher as you get older, that's PFR, but the relative risk is higher in middle age. So something's going on with population response to vaccination, which is leading to these very different patterns. Why do we see the drop in 2021? Two reasons. One, the older people are more likely to get vaccinated. But second, they're also doing a better job of staying out of the way of getting infected because they know it's likely to be serious, more likely. Let me skip over the two-dose vaccination rates. These are consistent with generally rising with age, but then it drops a little for the oldest group, the 75 plus. I wish I knew why. Milwaukee County, where we're studying, is close to the national average. I'll just skip over this quickly. Booster doses, again, booster probability rises with age. Okay, now let me go to CEMP by vaccination status in the vaccine available period, but before boosters. And the top line is CEMP by age, if you're unvaccinated, and the vaccines help. The dashed orange line is 1 dose and the green line is 2 doses. This is for all vaccines together, but in practice, almost all Pfizer and Moderna. On the other hand, once you get way out to the right to 80 plus, this is not the 90, 95% effectiveness that you read about in a bunch of other studies. And you can just see that by saying, okay, 2 doses is 2% and no doses is 5%. So what's the ratio? Like 40%. Okay, the vaccine is 60% effective, but it's not 90 or 95% effective. Not for the elderly. It's more effective for younger people. What's different here? We're controlling for background risk by measuring CEMP as the outcome rather than just population fatality rate. Let me switch to the booster available period through June 2022. And top line is unvaccinated. Okay. Now, you see that CEMP is still dropping for the elderly. This is because they're staying out of the way. And then 1 dose, 2 dose, 3 doses, going down, down, down. Notice that 1 dose versus 2 doses doesn't matter so much anymore. Once you allow for vaccine waning, right, for people who didn't go around get a booster, having 1 dose helps, and having 2 doses helps a little more, but not usually more, maybe because they were so close in time. And then having a booster helps, but again, we're not seeing a 90% reduction in having a booster versus having 1 or 2 doses. You would see higher percentages if you didn't control for the fact that the booster people are already healthier. Okay, next, we're going to define the vaccine available period into four periods. Starting April 1st, that's roughly when vaccines were widely available. We throw out the first quarter of 2021 when it was mostly available only to the elderly. Then we're going to have a kind of low period where we switch from the Alpha variant to the Delta variant. Then we've got Delta with boosters available, and we've got Omicron with boosters available. One of the limitations here is you can't study the effect of waning separately from the effect of different variants, because the variants just one replaces another so quickly. First, these are the selection effects, which I hadn't shown you before. Okay, this is non-COVID natural mortality rate during the Omicron period based on the number of doses that you got. And what you'll see is the 2-dose people have about half the mortality rate of the unvaccinated. 1 dose, not such a big difference. And that's true for younger people, and it's true for older people as well. And for 60 plus, the people who went and got a booster, the 53% at the bottom right, are substantially healthier based on their risk of dying of other things than the people who didn't go get a booster. Implication, it's also the case that the early vaccinees are healthier than the later vaccinees. Put all this together, if you don't account for selection effects, you're going to underestimate the effects of waning. Now, notice the percentage. No, this is not a waning percentage. Never mind. This slide is just for fun. Vaccination protects you against being killed in a car accident or being shot. I guess you didn't know that. But it does, rather strongly, especially for the young. These are selection effects, not vaccine effects. Okay, I want to define a relative mortality risk. It's a relative risk. It's an odds ratio. CEMP for the vaccinated versus the unvaccinated. We'll be able to do the same thing for Pfizer versus Moderna as well. And because these are odds ratios, you can recover them from logistic regression. So we'll be able to, I'll show you simple comparisons of two groups. That's what I've shown you so far. We'll get very similar results from multivariable logistic regression. Okay, so relative mortality risk, ratio of CEMPs in the Omicron period, where we've had more time for waning to take place. For 60 plus, remaining mortality risk is averaging about 34%. It's not 5%, it's not 10%, it's 34%. There's still substantial risk, even if you're vaccinated with 2 doses. But the 3rd dose helps. It takes the 34 down to 11. So this is a message saying 2 doses are waning and aren't doing as good a job as we thought, but the booster is still helping a lot. And indeed, in our sample, under age 59, now this is the small sample. This is 100,000 something people. We have no deaths among people with 3 doses. None, 0. In a bigger sample, I'm sure we'd get a few, right? But 3 doses is basically taking your risk down to 0 if you are under 59 or very close to 0. 2 doses helps, 3 doses helps more. A caveat, if you will. What does relative mortality risk mean? Increasingly, we're not comparing uninfected vaccinated to uninfected unvaccinated. Large portions of both populations are already infected. And so we're in many cases comparing infection-based protection to hybrid protection based on infection plus vaccination. And we don't know the mix of proportions because we don't know how many people have already been infected because we don't have the data. So the meaning of vaccine effectiveness is shifting over time as more and more people have already been infected. This is a waning chart. RMR rises over time, especially for the elderly. And so I'm showing you here, the green is 60 to 69. The dashed line is, I'm sorry. Yeah. Green is 60 to 79. Dashed line, stop. Okay. Let you read the chart, okay? The biggest waning is 2 doses. That's the dashed line. And that's quite substantial once we get to the Omicron period, right? That's the orange dashed line up at the top. And we're getting into RMRs on the order of 40 to 50%. 60 to 79, not as much waning. But the fact that the orange line is going up says we've got progressive waning. And then the solid lines are the booster. So the booster is helping. Before, I gave you a 34% relative mortality risk for ages 60 plus. Now I'm going to run a multivariate logit. I'm going to throw lots of stuff at this. I'm going to add in gender. I'm going to add in SES. I'm going to add in race, ethnicity. I'm going to add in education. I'm going to add in marital status and military veteran status, all the stuff we can dig out of death records. And the results don't move. Instead of 34.2, we get 32.9, which is telling you that the CEMP denominator is already doing a good job of controlling for other risk factors, because things like education and gender and race ethnicity do predict COVID mortality, but not after we control for CEMP. And then again, similar results for the 3rd dose. Its remaining risk is 11%. Let me go sideways for a minute. In order to use the denominator, which is non-COVID natural mortality, as a control, we have to do a good job of measuring COVID deaths. because the CEMP is the numerator over the denominator. If we underestimate deaths, we're going to overestimate the denominator. We're going to underestimate CEMP, right? That may or may not matter much for ratios of 1 dose versus 2 dose. But what this is meant to do is to say we're doing a good job of capturing COVID deaths. The red line is total deaths. We see the 2 big spikes in total mortality that are due to COVID, one in late 2020 and the second in late 2021, early 2022. The blue line is the non-COVID natural mortality rate after subtracting COVID. The dashed green line is what we predict extrapolating into the COVID period from the pre-COVID period. And what you're going to see is the blue versus the green sort of bounce around relative to each other, which is telling you that if we're undercounting, we're not undercounting by enough to measure. I won't show you confidence intervals, but we're not significantly undercounting COVID, and therefore our CEMP measure is at least unbiased in that sense. Okay, next topic, Pfizer versus Moderna, which we can also look at. General view is that Pfizer, BioNTech, and Moderna are both really good. They're better than AstraZeneca and J&J. They're similar in effectiveness to each other. Maybe today you would say there's a tilt to Moderna because it looks like it wanes more slowly. The initial clinical trials were, both were basically equivalent as best we could tell. There was no reason to prefer one over the other. But we can use the CEMP measure to compare vaccines. We can first ask, are there selection effects for which vaccine people chose at a time when there was no reason to choose because we thought they were the same, right? So how can there be selection effects? Well, there can be selection effects based on which vaccine was more available to which group. Moderna was available a little bit earlier and tended to get used more heavily for the oldest people who got vaccines first. Pfizer became more available later, overtook Moderna, and so was more heavily used by younger people, right? We're going to find strong selection effects. I'm going to show you those. The Pfizer vaccinees are healthier, controlling for age and gender, for the older people, which is where most of the mortality is. For younger people, it doesn't matter. There's no selection effects that we can find, or not meaningful ones. So here are the results for selection based on measuring non-COVID NMR. And Pfizer ratio to Moderna, if it's near 100, that means there isn't important selection. And for 18 to 39 and 40 to 59, we're not finding numbers that are significantly different than 100. Once we get to older people, the 2-dose Pfizer people are substantially healthier than the 2-dose Moderna. And that's largely true for 3-dose as well. For whatever reason, we don't have a good window into why, but we can observe that the 2-dose Pfizer people are substantially healthier. We see the same thing for non-natural mortality. The Pfizer vaccinees are less likely to get killed in a car crash or shot. Okay, so now we're going to use our CEMP measure, having justified using it, at least for age 60 plus. So this is limited to age 60 plus. We do not see significant differences between Pfizer and Moderna under age 60. They both work really well. We do see differences over age 60, so this is going to focus in on age over 60. So what do I want you to see? What I want you to see is the ratio of mortality for Pfizer versus Moderna for 2 doses is consistently in the 200 to 250% range. So you're twice as likely or a bit more to die of COVID if you got 2 doses of Pfizer versus 2 doses of Moderna. That won't be seen if you don't control for selection effects, for the Pfizer people being healthier, and the statistical significance is very strong. Overall, it's p less than 0.001. We also see that Pfizer waned more rapidly, and so the RMRs for Pfizer, before I was showing you numbers in the 30–40% range, for 80 plus, we're getting waning in the 70 to 75% range. right? So Pfizer 2 doses is helping the elderly, the 80 plus a little bit, but not that much. They really need the 3rd dose, right? And you see that because the 79% goes down to 17%, the 74 goes down to 15. So the 2-dose elderly Pfizer people really benefit from the 3rd dose. After booster, after the 3rd dose, the differences collapse. We no longer see statistically significant differences between Pfizer and Moderna. Maybe they would emerge over a longer period of time if we see faster waning for Pfizer than Moderna. That's possible, right? The point estimate is north of 100% in the Omicron period, but it's not statistically significant. So all I can say is with a bigger sample and more time, it might be that a Moderna advantage would emerge for the elderly as well. This is showing you similar results in the form of a chart. So what have we got? Unvaxxed is at the bottom. This is the CEMP ratio. And then the dashed lines are 2-dose Moderna or Pfizer, Moderna in blue, Pfizer in orange. And you see that Pfizer is not as effective as you get older. Younger, I don't see any difference between orange and blue, but for the elderly, a difference starts to emerge. This is for the booster available period, okay? So it's a 9-month period, and you could separate into Omicron versus Delta. Once we get to 3 doses, the 3rd dose helps, and there's no longer a significant difference between Pfizer and Moderna. RMRs, remaining mortality risk. For 2-dose Pfizer, age 60 plus, we're now up north of 50% remaining risk. So the vaccine is still helping, but you could take the upper orange line down to the lower orange line by getting a booster. And there's a big gap between those two. And once again, once you get a booster, we don't see much difference between the 2 vaccines. We can throw a multivariate logit model at this, where we're going to control for age, gender. We're going to control for days since the last vaccine dose. We're going to lag by 30 days because you don't die immediately after getting the vaccine. We're going to get similar results if we add SES, if we add race, ethnicity, if we add education. The covariates don't matter much, as we saw before for the general vaccine effectiveness. Once again, CEMP is doing a good job, but controlling for the fact that the Pfizer vaccinees got vaccinated earlier isn't changing results. And so once again, we're seeing numbers in the 200 to 250%, kind of consistent. So the waning is progressive, but the relative benefit of 2 doses for the elderly is consistent across time periods. And once again, nothing for the non-elderly. And for 3 doses, we don't have any deaths in our sample. So 3 doses of either one was pretty good. And for the elderly, again, the percentages are above 100% in general, but not yet statistically significant. We need a much bigger sample to say much. Tentative results. Pfizer 2-dose is less effective for men than for women. Where do we see that? That's the solid blue line, Pfizer 2 male versus Pfizer 2 female. Now, that's really tentative, right? My t-statistic for the difference is 2.04, right? I don't trust a t-statistic less than 3. But I wanted to show you that because it would be consistent with other evidence that vaccines are more effective for women than for men. So why is Moderna better for the elderly? Well, we don't know. Our data can't tell us. Probably it's the higher dosage. Moderna dosage was 100 micrograms versus 30 for Pfizer. Let me compare that to the flu vaccine, where we've learned over time the flu for the elderly is now 4 times the dose. I'd love to see a good study of let's start varying the COVID dose and see what difference it makes once we allow the vaccines to wane over time. So but where we are now, for the elderly, I'd say you should tilt toward Moderna. But for young men, I'd probably tilt to Pfizer because the myocarditis risk is higher for Moderna, probably because of the higher dose. So it becomes a complicated story. What can we say about fourth dose? Yes, for ages 60 plus. Under that, we have no evidence. You're not going to die anyway, and you're unlikely to be in the hospital. Israeli data for Pfizer only is consistent. They see a benefit of the fourth dose for ages 60 plus, but not for younger people. Let me say something about what our public health messaging has been and maybe should be. It has been, get vaccinated and any vaccine is good. And that's true, but for the elderly, Moderna is better, at least up to 2 doses. Now, it's hard for the CDC to say that. Indeed, the CDC studies combine the two mRNA vaccines and just report a combined result. They're hiding the differences that might exist. The message has been both mRNA vaccines provide strong protection against severe disease. And so people hear, well, a booster would be nice to have, but it's not so important. No, it's really important. The booster is really important for ages 60 plus, and we're just getting that wrong. The more accurate message, I think, supported by our data is if you're 60 plus, get a booster and probably Moderna and get a fourth dose after a while. And for younger people, it doesn't matter so much. 3 doses is enough so far, maybe 2 doses if you're already infected. That's a more complicated message, but it's closer to our data. Okay, last thing I want to do, and I'm keeping an eye on the clock, and so I want to leave time for questions. Life expectancy loss to date, right? We don't know the future. Ballpark estimate. Measure your life expectancy conditioned on age and gender and whatever else. If you didn't die of COVID, the cohort measure of life expectancy loss from the demography literature is we just sum the life expectancies of the decedents over all decedents and divide by population, and you're done. Really simple. So back of the envelope, we've had a bit over 1 million deaths in the US. That's 0.003 of the population. The average life years lost is about 12. Let me multiply. 0.003 times 12 is 0.036 years, which is 13 days. Not the 1 year or 2 years or 3 years you see in the literature. This is it. This is the more details. So very, very small life expectancy loss for the young. It gets up to meaningful number of months for the elderly in here, right? We're up to about 0.13 or 0.14 of a year. So that's getting to be a couple of months. But that's on a population basis, you know, that's offset by the very small numbers for the young. Higher for men than for women, higher for Blacks and Hispanics than for whites, lower for Asians. But overall, those are the numbers we should be talking about, not the 2 years. All I can tell you is this message must be politically incorrect. I have a new personal record of getting desk rejected with this message 7 times in a row. The medical journals don't want to hear it. They don't want to hear a story that COVID wasn't as bad as they want the world to believe, right? But the logic is just impeccable here. To date, the life expectancy loss is 13 days. Why are you hearing 2, 3, or 4 years? Because demographers are using a period measure, which assumes COVID will last forever at the last year's intensity. But it won't. We know it won't. A better measure might be a hybrid, which is measure the life expectancy loss to date, and then project into the future based on what we know now about what future mortality is going to be. That might add another week or so. That's a back of the envelope estimate, right? So we might end up at 3 weeks of life expectancy loss instead of 2 weeks, but it isn't going to be 2 years. Let me stop there and open up for questions. Sir.
So thank you for a very provocative talk. So I'm an infectious disease doctor, so I've been following this pretty carefully for the last couple of years. Not everything you said was correct. So for example, in the original Moderna and Pfizer studies, there were some deaths. So I think there were 7 or 10 deaths in the unvaccinated group versus 0 in the vaccinated group. Even in the early study that came out, a year and a half ago, there were significant data that you would be protected from death following the vaccine. And the 90, no one quoted 95% rates for everybody. Everybody, even in those original studies, we knew that the numbers were lower in the elderly. And those studies actually had about 20% elderly. They purposely tried to recruit old people. You don't usually do that when you for vaccine because you want it to be safe. But so they recruited a lot of older people, and they showed about 70 or 80% protection for the elderly, in the early days against infection. But there were some trials that there was one trial that had a group in South Africa, I think, where they had 7 or 10 deaths in the unvaccinated. So there was some data there. Also, I don't understand what you're trying to do with the mortality. How does the 14 days work out with those 2 huge blips in mortality in the population?
So the initial trials were what they were. The Pfizer and Moderna trials had very small numbers of deaths. I forget the exact numbers, but let's not argue about it. They weren't aiming at, the outcome was infection. The outcome was not hospitalization or death.
When they looked at the deaths.
No, it couldn't have been. The numbers weren't big enough. But let's pass that. I'm familiar with the studies. The South Africa study, I think, would have been AstraZeneca. This is the calculation, right? It's really simple. That takes into account the 2 peaks. We could look at the incremental life expectancy loss by period, but this is where we are. Now, it's 2 or 3 months for the elderly, and it might be 4 months for the Hispanic elderly. And those are big numbers. Yes, it did in 2021, and it's come back up in 2022. But average over the whole period. So the calculation here is on an individual basis, right? We're estimating remaining life expectancy on an individual basis, controlling for everything we can control for, and then just adding up to get life years lost, and from that to get life expectancy. I think this is a solid calculation, I really do. And it's very different than the period calculation, but it almost has to be right. So let's, yeah, Lori.
Okay, so a couple questions here. As a demographer, you have to die from something, right?
Yep.
And so if you only are subjecting people to COVID deaths, then you're missing out on other ones. And then also we cleared out all those sick and frail people during 2020 from COVID, so they weren't eligible to die in 2021 or in 2022.
So we clearly, some people who died of COVID in 2020 might have died of something else instead, right? And then obviously couldn't die again.
Right. So if you don't die
of that in the data, I didn't focus on it. Where do we see hints of that? If you look in early 2021, the blue line is below the green. And if I had confidence intervals, sometimes it'll be significantly below the green. So we have fewer non-COVID natural deaths than you would have predicted based on prior history. And we're seeing the same thing now in the middle of 2022. So that might be an effect that is visible in the mortality data, but I don't want to be too confident about that. But I don't know what that has to do with how that would affect the results that were reported. Unless it's a big offset that lots of people died of COVID who would have died by now anyway. And I don't think it's a big offset. It might be a bit of an offset.
They have to die off from something. So if you remove COVID, you die.
So this would suggest that the 13 days is an overestimate. From what I've seen, I don't think it's much of an overestimate. Other questions? Yeah, Adele.
So we have a question from a participant online. When talking about LEL, is this in reference to patients who have been infected with COVID or in reference to patients who have not been vaccinated?
So this is everybody. This is the whole population. Just looking at, we know who died of COVID. We think we're doing a good job of measuring that and not undercounting it. And we can estimate their life expectancy if they hadn't died of COVID. And that's going to be in the column for COVID decedents. And then we can multiply to get life years lost and add those up and divide by population. So it's you had to be infected of COVID to die of COVID, but it doesn't depend on vaccination status. Surely these numbers would have been higher if we didn't have lots of people vaccinated. Yeah.
There's another question from online. Anna says, thank you for the very provocative talk. Did you take into account a possible decrease in the risk of natural deaths due to social isolation and other factors that would not occur in a natural setting? I.e., what would the calculation look like if lots of people who didn't die of natural death would have died without the onset of COVID?
So we can't measure that directly, right? I don't think there is evidence that is convincing for me that the effects of social isolation, which were mostly in 2020, had an important effect on mortality. So for example, people were worried that suicide would go up and it didn't, right? We thought motor vehicle accidents might go down because fewer people were driving, but they were driving more recklessly, so motor vehicle deaths didn't go down. But for natural death, I don't know that I would expect, that's not social isolation. And so that's part of why we want to use non-COVID natural death as we think a better predictor of health than all non-COVID death. And that's been an evolution in our research strategy. Yeah.
I'm going to start out by saying I'm not a statistician, but I guess I'm left with the question. I'm sort of left with a question of why you did the LEL calculation. When we think about like the effects of long COVID, the vascular issue, you have really no sense of what this is going to do or how this is going to play out. And it kind of feels like you're crunching numbers to crunch numbers. But so I'm wondering why.
Okay, so the question is, what are we missing by not taking into account long COVID, right? And it's clear that we're not. What would I say about the implications of long COVID for mortality, which is all that we're studying, okay? What I would say is, in aggregate, it's not big as best we can tell right now. There is a short-term effect in increase in cardiac deaths. There is a short-term effect in increase in stroke deaths. But the best research I've seen says that lasts for about 3 months or so. And after that, mortality rates are kind of back to where they were before. And it's not a big number in the aggregate. If it was, it would show up in our non-COVID natural mortality rate after the COVID peaks. And we're not seeing that. So our aggregate data is consistent with these more micro studies. That's not to say long COVID isn't a disaster for some people. It doesn't, looks like for most people, you're okay after a year from some recent research, but it's not, long COVID isn't hitting mortality statistics in a major way as best I can tell right now.
So
Yeah.
mainstream narrative. But I think actually the pandemic has lasted for 3 years, and many has changed. Like the bio has become from one version to now to outcome, and they have some also like some case for example they have defined die of COVID-19 and now they change and they use like die COVID-19 now they change to die of COVID-19. So I think you have a lot of information, but I think for some reason the editors they don't like your conclusion.
Isn't that interesting? We're revising. So the question is, you know, because I know the Zoom can't hear it. The vaccine variant has changed. Yes, it has. And we don't have a good way of asking if we could keep the vaccine variant the same, what results would we get? We can't do that because one replaces another too quickly. So we don't really see both circulating at the same time. We have this problem, which I mentioned, which is more and more people are infected, both vaccinated and unvaccinated. So more and more, when we measure vaccine effectiveness, we're comparing infected but unvaccinated to infected plus vaccinated, but we don't know the proportion of infected in each. What we'd really need to have is a really large-scale antibody study, so we know how many people are infected and how many people in each group, and we just don't have that data. So it's just a limitation. It means that vaccine effectiveness doesn't mean what it meant in early 2021, when many fewer people were infected. I don't know. I scratch my head. We're going to revise the life expectancy loss paper, and I'm going to send it to a health economics journal because I know how to publish there. Right? I don't know what's going on. I find the process remarkably frustrating. But it's on SSRN, Social Science Research Network, and so the results are out there. Other questions?
I think we're at the end of our time, so I want to thank Dr. Black. Thank you so much for your very interesting talk.
Thank you.